So it's obligatory at conferences like this to really start out with a joke about how poorly all the healthcare professionals are doing because everybody's patients dies. I'm not going to do that. We're going to do something a little bit different. Who here, show of hands, who's heard of Z-Dog? Oh, not too many of you. Good. Oh, you're in for a treat. And I'm about to do a little commercial because my staff is here and they'll be angry if I don't. On October 14th, Friday, October 14th at Riverworks, the P2 Collaborative is hosting a conference and Z-Dog will be performing live. So if you want to meet Z-Dog, Z-Dog is a Stanford-educated molecular biologist and doctor. He started a primary care clinic in inner city Las Vegas, and he's also a rapper. And he does raps around healthcare issues. So he's October 14th, make a note of the date. And so Z-Dog has done this particular video. It's to the tune of a Rihanna and Eminem song. I don't know, I'm looking around the crowd. I think most people probably know who Rihanna and Eminem are. But this is a takeoff on that. And it's both fun and very, very serious. So I hope you'll find this as moving as I do.
Just gonna stand there and watch me burn. Is love life and all my wishes go unheard? They just prolong me and don't ask why. But it's not right, 'cause this ain't the way to die. This ain't the way to die.
I can't tell you what I really want. You can only guess what it feels like. And right now it's a steel knife in my windpipe. I can't breathe, but you still fight, 'cause you can fight. Long as the wrong's done right, protocol's tight. How the drugs, drugs sedate. I'm like a pin cushion, I hate it. The more I suffer, I suffocate right before home.
So not too many people have heard of Z-Dog. That was a small, but I guarantee, let's do this now. How many people here have heard of Katie Grimm? Yeah, there we go. There we go. More famous than Z-Dog, Katie. Put that on your resume. So we're going to have breaks, and this is going to be a real nice combination of speakers, panel discussion, Q&A, and then some skits at the end. So it's something for everyone. We're very, very excited. And frankly, our two speakers who are going to kick us off are two people who are going to give us a couple of different perspectives. Wonderful, wonderful people. Very, very knowledgeable. So Dr. Katie Grimm, who is known to all of us. I'm not going to read her bio, it's there. And then I'm sorry, not Doctor. I guess that's a promotion. Krista Gottlieb. And I asked Krista how she wanted to be introduced, and she said her ladyship. So there you go, Krista Gottlieb. So we've got a medical perspective and a legal perspective, but even more than that, more human perspective. So two really, really terrific speakers. We're looking forward to having them. We'll ask Katie to come up right now. Thank you.
So this is for my team. It's KGMD. We've shown Z-Dog in many, many settings, and it's so meaningful because of the work I do. I do work in palliative care at UCMC, so part of what I hope to speak to all of you about today comes a little bit from the perspective that I have from dealing with people when they are in a crisis situation. But I'm not going to contradict my friend John, but do want to leave you with some resources at the end of this talk so that you hopefully will leave saying, I really did get some good meat out of these talks. So I know that people, I don't want people to think that I am anti-form, but I think in the work we do, we are realizing more and more, and not just those of us that do this work in Buffalo, New York, but in several areas across the country, conferences that we've gone to, the theme that is resonating everywhere is that we have to have these conversations. We have to get at the values of these people that we're caring for, so that we understand when we're presenting menus of interventions, they have a better understanding, or we have a better way of translating what we're offering into the values that they're representing. So that's where I hope to start this talk. So why are we here? I hope many of you have read, if you haven't heard of Z-Dog, that you've heard of Atul Gawande. And Dr. Gawande and his book Being Mortal was at the New York Times bestseller list for many, many weeks. And it was his look at his own father's experience of dying and his then really the way he writes is just so beautiful, but his look at the world of death and dying and how we treat our aging. So he said, our reluctance to honestly examine the experience of aging and dying has actually increased the harm we inflict on people and denied them the most basic comforts they need. And I love the little cartoon there because my name is Dr. Grimm, so you can only imagine when I walk into rooms and introduce myself as, hi, I'm Dr. Grimm from palliative care, what the response is. So, which is why I really want to talk about values-based conversations way ahead of the time they meet Dr. Grimm. So this is the real reason that I believe we're all here. And these, I'm going to just show these real quickly. But this is the reality of American medicine. It really is. There has been this, I think that the system that we've built, or that now exists, is that we deal with these conversations in the idea or the concept that people are going to live a life for a long time and then reach the age of 99 and then suddenly go to sleep and then not wake up. And that's how people will die. And they'll all be prepared for that, and they'll create these lovely forms and talk to their family and all have a very natural, comfortable death. That's what we'd all love. But the reality is that 80% of Americans will have a slower, more predictable trajectory over time. And they will die of probably 2 or more chronic diseases. My colleagues here from Landmark, are working in that field, I believe, and see that, this is the trajectory. We have more and more ways to offer interventions. People are living longer and longer with dementia. They're living longer and longer with COPD, congestive heart failure. And my colleagues in primary care probably, when I would recognize this trajectory, and when I was meeting with some of them before this meeting, they said, we have so many opportunities, and this is what this graph, I think, represents. These are the unbelievable amounts of opportunities we all have to talk to the people we care for and try to understand, what do they understand of their illness, and how would they want us to care for them if they get sick, not if, as they get sicker, as they move through this trajectory. So it's more about grabbing these opportunities and having these conversations. So it's a continuum. It's a continuum. I, again, want to be very respectful of all my colleagues here, but we have really created a system where we talk about end-of-life wishes. And I would dare say that anyone sitting in this room is thinking about dying right now. But you all sitting in this room know who you are and what your values are. And the culture change, if I could say one thing or do one thing even this morning, would be to say some of you might take some of the resources I'm going to share with you and go home and try to start to create for yourself what might be the value you would hope would be respected as you move through a trajectory. Or if you were faced with a sudden crisis in your life. I work at ECMC, Trauma Center. And I think that creates in most people's minds an idea that we're dealing with a lot of 20-year-olds with gunshot wounds. But that's not the reality. We're dealing with 85-year-olds who are in car accidents, who have never had a conversation with anyone, family, doctor, anyone in their family, about what would my wishes be if I were faced with a sudden crisis or a sudden illness or a sudden disability. What the families do know, where we often have to back way up and get to when we're doing this work, what the families can tell us is who that person was, how they lived their life, what was important to them, and then we can often then help them make decisions based on that. And the hope today in talking about value-based conversations is to shift all of our thinking a little bit upstream to that process, where we can start talking to all the people we care for as they move through any trajectory of illness, but even when they're healthy. This conversation continuum starts when people are healthy. And I worked as a primary care physician. I don't know how many primary care physicians are here, but I see some of my colleagues. And I think asking a 21-year-old about their end-of-life wishes is like talking to them about a lot of other things we talk to 21-year-olds about, in one ear out the other. But I can talk to a 21-year-old about, hey, what are you seeing in your world? What's important to you? Tell me who you are. Or even share with them, I've seen some of your friends, you've seen the headlines of these people dying from opioids. That's sort of scary. We're seeing that in the hospital. I worry. Have you ever, thought about if you were ever in a car accident? These are conversations that sometimes seem hard, But it's groundwork that I think we can all lay a little bit if we shift it to who is this person and what is their value. The Conversation Project, this is one of the resources I'm going to spend just a little bit of time on because it's one of the resources I hope to leave you with. This is a free tool that anyone can get on their website, conversationproject.org. It's a national social media campaign. This is nationally being pushed out to do just what I'm asking of this group here and probably asking in every corner of the world that I touch. Can we start having these conversations? And can we base these conversations more on who are you and what would you like if you were ever in a crisis situation? So you might say, well, I don't know. And I say, you're right, there's a lot of medical interventions we could offer. But you probably sitting there could say just what Z-Dog said. I don't want to be a vegetable. And the challenge then is, tell me what that means to you. To one person that could mean one thing, to another person something entirely different. But help us to understand what that means, and we can then work with you on what you might want to ask for if you're faced with an intervention. So, I don't want to be a vegetable is a value. In a way, it's a value statement. How do we work to translate that? And I think we work by not waiting until someone is in that state, that someone might be unresponsive, faced with a sudden crisis, that we could have predicted if we had taken the time, maybe 2 to 3 years upstream, to have conversations with them, take those opportunities. Dr. Ira Byock, who anyone who may do palliative care knows this name, is an important name in palliative care. And he actually speaks to the forms, but he speaks to them, I think, in the manner that I hope, we all can start to wrap our minds around. He says, I have a directive, a proxy, not because I have an illness, it's because I love my family. And I cannot stress enough the passion that I have around this is because of the numbers of families. And I know many of my colleagues in palliative care and the people I work with at ECMC could get up here and tell you story after story after story after story of families that are grieving much more than they may need to because they really have never had those conversations. And they're left with the burden, really, of trying to help us understand what would this person have wanted, what would they have wished us to do, how would they have wanted us to care for them if they were in this position. So a directive is important, but again, Krista, I don't want to steal your thunder, but in New York State, some of the directives actually that we use, including the proxy, and I only realize this as I do this work, we do a lot of work to create proxies and it's very important. But in New York State, what's really interesting is the proxy form does not designate that you've actually talked to your proxy. You can get 2 witnesses to sign your proxy form. And we always do this in audiences. I say, okay, so I'm going to name Jackie my proxy, and I'm going to ask Dr. Mylott, and I'll ask Dr. Deb to be the witnesses. I'm going to do that, but I did that wrong. I'm not going to ask Jackie, but I'm going to decide that Jackie's my proxy, and I'm going to ask these 2 to be witnesses and never talk to her. So if I leave here and I get in a car accident, they're going to reach for that proxy form, call Jackie, and Jackie's going to go, I don't know, she was an old lady with a lot of passion, but I don't know. I have no idea what she would have wanted. I don't know what her quality of living, how she would have described it, or how she would have described what her wishes were. So I think we need to, my hope is that we use some of the tools that are actually out there, the Conversation Project, those tools that are readily available to say, can we start having these conversations? Can our doctors, our nurses, our medical assistants, those of us that are in our offices, any place where people are coming for care, can we start sharing these toolkits and saying, here, I'm worried about, maybe you're getting a little sicker and I need to create a care plan that really addresses who you are and what's important to you. So maybe you want to start working on this with your family and then you and your family can come talk to me sometime. And that, my colleagues are going to say, yeah, when do I have the time? But that's a conversation for another day. Conversations are in some way are deconstructing, I think, a little bit the concept that we have about the directive. Because we have to be understanding that none of us are always going to know the moment of, when our death may occur. We may be the 80% of Americans that will travel through chronic illness and be able to work with the people that care for us to go through that with them and change what we think as we go through it. But the worry and the reality of what we see is if we see the form as a static document that's created at one point, as we move through that trajectory, and it's never readdressed, going back to the conversation, if I name Jackie now, but 10 years from now, I'm not even in Buffalo, New York, but I've never resurrected that form and re-engaged in that conversation, we're really lost when we try to create value-based care. Joanne Lynn says it very well. Joanne, for many of you who may be working in geriatrics, is a geriatrician who's done a lot of work at end-of-life planning and trying to understand how to better do this. She said it's about planning for the what-ifs. What if? All the way across the lifespan. So from the young and healthy all the way to the old. If we wait until people are 85 and end up in the trauma unit from a car accident, we've missed enormous time and opportunity to have conversations with people. And it's conversations about who they are, what they value, and what care they think would be appropriate. So tell us what you mean when you say, I don't want to be a vegetable. So what's happened in our system, and at least in the hospital, is because these conversations are so sparse and they're not happening, excuse me, I'm a little bit of a cold. They're so, sparse and not happening as frequently as we would hope when we see people in the hospital, that oftentimes we're meeting them and their families after they've known a primary care physician, after they've known an oncologist or cardiologist or a neurologist or all their specialists for sometimes 10 years. And we are meeting them in the hospital for the very first time, and the hospitalists or whoever, not doing any wrong, but it's just the way the system works, are saying, oh, you need to have this conversation, I'm going to call palliative care. And then watch Dr. Grimm, right? Okay. So the system has created it that, I can't have this conversation, therefore I'm going to pass it off. But I think part of that is because we are so caught up, I think, in that end-of-life wishes has to happen when you're facing a crisis. When really end-of-life discussions maybe don't need to be about end-of-life, like do I want a ventilator, do I not want a ventilator? I'm not sure, but I'll tell you what I do know. I know about me, Dr. Katie Grimm, what's important to me. I had patients say to me, I'm a fighter, and I would say, of course, and I'm not going to stop fighting. We're all going to fight, that's what we do. I've never met someone that, well, I can't say never say never and always in medicine, but I don't think we meet people very often in medicine that say, I'm ready. Yeah, give it all up. I've lived it. What they will say is, I'm tired. I really hurt. I really would like you to offer me an option. But people want to live and they want to fight. So our language has been about end of life as giving up, as not moving forward, where I think we have to shift it back, way back to say, no, we are going to continue to always care, but it has to be based on the premise of who you are and what you see as a quality of life. My definition of quality, I need to know when you say you don't want to be a vegetable, tell me what that means to you. Because some people will honestly say to me, I'll go on a ventilator, that's okay. And I need, so it's working on these conversations. So I'm working at the far end. I think I'm standing here imploring everyone who's not in the hospital to help us. The hospital should be the last place, I think, where it's just the final handoff and a nice warm handoff, where I get a patient from wherever, whatever corner of care they may come from, but they've already had multiple conversations with the people that they know and they love, and especially have had those conversations with their family. The other part that's a little difficult too is we often get caught up in this, menu choices. Do you want this? Do you want that? Do you want this? Do you want that? That's a difficult thing for patients. And then certainly we would need a whole other hour or whole half-day seminar probably to help people maybe move around that construct of how do we move away from menu choices. I don't know if you guys read the New York Times. Part of the work that we're doing in the Conversation Project is we're involved, the ECMC and the work we're doing there. We're involved in a Conversation Project national consortium, a community of learning. So we get lots of articles sent to us. What do you need in your email box? More articles, right? But some of them are really good. There was just one that was passed to us this week by a doctor from up at Harvard, working at Massachusetts General. His name is Dr. Z, resident physician actually. I'm looking for his name. Dr. Kruller, I believe. But this menu option is really difficult not only for our patients, but for the physicians and nurses, medical, anyone in the care system who's taking care of people. And he captures it very well. He said, despite tremendous advances in healthcare, most medicine still exists in a gray zone. We're working in a trajectory that's often not perfectly predictable, but some outcomes can be predictable over time. But some instances in the care we're giving aren't always predictable. There aren't always right or wrong answers, but rather a continuum of risks and benefits, that continuum. What is your biggest worry about this intervention? Are the questions we ask. Circumstances exist in which diagnosis and treatment are clear. A ruptured appendix, for example, there's no gray zone there. Well, there is actually now. Now the Canadians are using antibiotics, but those crazy Canadians, we don't know what they're doing. Or a life-threatening heart attack. You hope that people don't get into a gray zone with that and jump right on it and take care of it. But for most conditions, there are several reasonable options. Important trade-offs, what's important to the person, and uncertainty about how well each one would work. So the uncertainty of medicine is a little bit hard when we're asking people to make hard choices. And what is never uncertain is the person and their own personal values and belief systems, and their experience, and their expertise, and their disease, and their life, and their relationships. Oops. So Dr. Davis says we have an obligation not to make diseases surprises. It shouldn't be surprised that dementia, once someone has to give up their car keys and is living with several aides to try to get them up and get moving and get dressed, that it's a surprise to the family of where that's going. But often it is, and I see some heads nodding like this is our experience, that oftentimes we see patients and families, and it's a total surprise when the Grim Reaper comes in and says, did anyone ever talk to you about where this dementia might go? Congestive heart failure. Not this perfect trajectory of you like this and you go like you drop off, but ups and downs, better and worse, but there's an outcome that I think is somewhat predictable. The hard part of what Dr. Davis said is accurate prognosis is needed for care planning, and it may be what has disengaged a lot of these conversations because people feel uncomfortable about accurate prognosis. But I would maybe pull apart a little bit that term accurate and go back to my issue of dementia and say, but we can predict, or we can be reasonably certain to say to a family, I'm worried that your time is short. I'm worried that we're headed for harder obstacles and barriers. I'd like to talk to you about that and see where we can come up with a care plan that makes sense for the person that you know, that I know from my view as a medical provider, but that you know as well. So if we can make diseases not surprises, we will create better care. Here's a resource, free to everyone. It's the Conversation Project. I don't think, we did not bring toolkits, but that's okay. You can go on the website. There are toolkits if you go on conversationproject.org. This is a national social media campaign to get patients, I should say people, before their patients, everyone in the community to start working with their families and with themselves to identify, using this toolkit, their values and what's important to them. So that when their physician, their nurse practitioner, their care provider says to them, I'd like to talk to you about where this disease is going and I'd like to create some plan and really talk about interventions, they also have had the conversation at home and can say, you're right, I've talked about this and here's what's important to me, and so maybe we can work together to come up with a plan. So the Conversation Project is trying to create cultural change, and I'm very sincere as I stand here and say, I'd really love to see this change start in this room. If all the attendees at this conference just looked at that toolkit, did it for themselves, tried to do it with their family, it would start to create the change, to say, all of us need to not only ask our patients to do this, but to do this for ourselves, and really start to create these cultural change conversations about what is important. So the Conversation Project is bringing awareness to the importance of these conversations. The tools are online. I know a very large major medical center that just started handing out Conversation Project toolkits, not locally, but a well-known one, UPMC, who just in their outpatient clinics was handing out these toolkits to the people they felt should be having those conversations at the kitchen table, so that the doctors, when they tried to engage them in the conversation, both sides were better prepared to sit down and say, I'm not bringing up something that you're not having a conversation about. So I'm stuck here, John. I wanted to show you a video, but I'm stuck here. My wheel isn't working. Now it will work too quick. There's a little video about the Conversation Project that I wanted to, the wheel is just going crazy, sorry you guys. And I can fill in project just so you can get that, how this works as a national media campaign too. If we can't, Krista, if we can't show it, that's fine, I can keep going. So the goal is actually to stimulate authentic dialogue. If you go to the conversationproject.org, that's a bad picture of Diane, but we can show it. If it won't catch, that's fine. So you can see it's from a Windows 10. That must be the issue. Windows 10. If we can't show it, that's fine. I can keep going. So if you get a chance, that's on the conversationproject.org website. And it shows a family having the conversation. What's interesting about this conversation is it's intended to have the elderly father engage with his daughter in the conversation, but as the family talks, what's striking is that the young children, the young 20-something-year-olds in the family start to chime in with, wow, I never thought about that, but if I could never talk, maybe I wouldn't want you to just keep going. So it's about starting that conversation at home. All right, I must have the wrong fingers for this, John, but it won't move. So the goal is, I've tried to say many times, is to stimulate authentic dialogue. And I'll give you one other example that's just happened to me this week too, and how real this is in the everyday lives that we lead. So I had a nurse that works in the nursing home come up to me, rather distraught, tearful. Her sister, who was diagnosed, it was a friend who was diagnosed with breast cancer, just had another lesion discovered in her lung. She'd been okay, had gone 5 years cancer-free, but had a problem and had a spot on her lung. And this friend, they were both shared nursing experiences. They both worked in an ICU. They were both trying to figure out how to tell their families how to be prepared for what was ahead. And this friend said to the nurse that I was talking to, the friend said, I don't want to be a tapper. What's a tapper? And she said, oh, in ICU nurse lingo, that's the patient who can't talk, can't move, is ventilated, but tapping all the time to try to communicate. And she said, how do I help her husband do this? And I said, well, why, because they were stuck on trying to create advanced directives and work with it. I said, maybe you need to start with talking to him about what a tapper is, because that was news to me, and letting him know that that's what she didn't want to be, a tapper. And that's the authentic dialogue that's now being, I think, really pushed out in the national media, in major medical centers. One other resource I want to leave you with, just because I don't want to leave this audience with thinking, oh, there's nothing we can really use, but this is a wonderful project. that's in this continuum. So if families at home are having these conversations, and then they're coming into the doctor's office and they're going through a 2 or 3 year trajectory of illness, there's something called the Serious Illness Conversation Guide. And for those of you who are in the look at the medical literature, this was published in the Journal of the American Medical Association in 2014. And once again, this guide has patient-tested language, and it's not about hard choices, but it's about looking at how do I understand what you understand about your illness, and then inviting ourselves in to say, can I share with you what I'm worried about? It actually also gives us this wonderful framework that's easy and everyone can use. That's called the Wish, Worry, Wonder framework. So there's many people in healthcare. John started the talk by saying, physicians, it's been shown that health professionals are not frightened, but uncomfortable with some of these conversations because there's this worry about taking away hope. So if a patient says, I'm a fighter, I want to continue this, the Wish, Worry, Wonder framework gives us the opportunity to say, I'm going to fight with you. I wish for a miracle like you do. It doesn't disengage their hope. We can wish and hope with them. But we have the job to be worried. We're worried about where this disease is going and what challenges lie ahead of you. And in that worry, I wonder if you're faced with a sudden crisis, how I might help you get the care you need. So Wish, Worry, Wonder, simple framework, easier conversation, not about a DNR, DNI necessarily, but advising on a DNR, DNI when we start to wonder together where the disease is headed. So I'm going to end up on a couple of notes. I was going to show you a wonderful video of Dr. Atul Gawande, but I'm having a little trouble with the PowerPoint here. Dr. Gawande, because of his, I can show it. Okay, I'll show it. Dr. Gawande, who captures everything I said in the last 25 minutes in 3 minutes. So maybe you'll remember him and not me. But he'll say in 3 minutes what I tried to say in a long time.
Good morning. Being handed from 1 kg to another kg. It just occurred to me this morning, you're going from Katie Grimm to Krista Gottlieb, who speaks a lot louder than Katie Grimm. Can you hear that okay? Because I don't want to talk too loud and have it reverberate too much. So the journey that I will take you on to continue from Dr. Grimm's is to look at how to facilitate those conversations. What Dr. Grimm has told us, and I think is very important for all of us to focus on, is getting folks to have that conversation. It's one thing to say, you should be having this conversation, go have it with the people you need to have it with. It's something else if they can't do that very effectively, or if that conversation leads to conflict. So I probably come at this from a very different paradigm. Because one way I could start this conversation is by saying, good morning, my name is Krista Gottlieb, and I do not speak English. Because that is what I said 50 years ago this past August when I got off the plane as an immigrant from what was then Czechoslovakia. And English was not a language I spoke at all. All I could say is what I just said. And that would give me a very different perspective on a whole lot of things than most people in this room, and frankly most people in a lot of different places. That diversity becomes important when we are talking about having these conversations, because you have to keep those kinds of things in mind as to who it is that you're talking to about having these conversations and with whom they will be having them. I come at this from not so much a legal point of view, although I am an attorney. I've been a practicing attorney for 36 years, but for 21 of those 36 years, I have been essentially a practicing neutral, and I am almost a full-time neutral now, primarily a mediator, but on occasion an arbitrator. And the difference between mediators and arbitrators, which I think is important for our discussion here today, is that arbitrators are sort of like judges. They make decisions for other people. people come to me and they make arguments to me and they try to convince me as an arbitrator to rule their way and do what they want done. And then the other side does the same thing. And then I make a decision, and that decision may be very different because my paradigm may be very different from either of the presenters. And I make a decision for them. And they are lifted of the burden of having to make their own decision. They may not like what I tell them, but they don't have to take responsibility for the outcome. Mediators, which is what I do most of the time, facilitate the discussion between the parties to allow the parties to reach their own agreement. We call it party self-determination. It means that the participants are making their own decision. They're doing it together. It is not a unilateral process. That's why it is a facilitated conversation. It's not me saying, this is what you're going to do, or I'm going to do, or we're going to do. This is me saying, okay, what would you like to do? This is what I'd like to do, and how do we make that work together? And as a mediator, I facilitate that discussion, not to make a decision for them, but to help them see each other's perspectives and point of view. That becomes a very important distinction in the context of what we are talking here about today in terms of the logistics, and my official title is Legal and Logistical Issues and the Impact on Family Dynamics. So the legal issue component of this is what needs to be legally done to effectuate the outcome of these conversations that people will be having and that you may be facilitating, encouraging, or sending people to have. Ultimately, at the end of the conversation, there is an outcome. What does that outcome look like, and how do we document it so that it is honored in the appropriate way? And from the mediated point of view is, if those folks are not having a meaningful conversation, how can you facilitate it becoming more meaningful? When you have a daughter and a husband, or a sister and a brother arguing about what should happen to mom or wife, and they can't come to an agreement, how can you help them? Either before mom has a need, or with mom there participating in that discussion. Very frequently, the way I sort of came to these facilitated discussions is, as a mediator, I would get involved with elder law issues, or what we call elder law issues, anything with the aging population, end-of-life planning, not only health-wise, but wealth-wise, and making decisions and what that looks like, and who you should be talking with, and what is the likely conflict that you can avoid, because it's all about being proactive. And I think that Dr. Grimm's presentation sort of highlights that, and I repeat that all the time. Proactive in order to prevent, in order to de-escalate, and in order to avoid conflict and misunderstanding or lack of understanding about what people want. So that's what we want to facilitate the discussion about. And it is something that still isn't as well thought of in terms of advanced planning. And so I have these conversations with lawyers because, like doctors have opportunities for conversations, lawyers do too. When people come in and want to make a will, that's a really good time to have that conversation. Or if people are not coming in to make a will, you want to talk to them about the possibility of making a will. And all of the things that go with that planning. If you're thinking about what should happen when I die, that sort of back it up a little bit. What should happen before I die if I don't die instantly and unexpectedly? And those conversations can be very difficult conversations. And one of the things that we do as mediators is to facilitate those difficult conversations. And what we try to do is do it in a way that leads to what is basically informed decision making. And whether it's picking off of menus or whether it's just having a general conversation, it allows people to have information. And if you don't have that conversation, you won't have any idea what mom wants. And mom won't have any idea of the impact it's going to have on the kids. And I think that's one of the important components to remember is that the patient, the person making the decision, and that you're having the conversation with about what are their end-of-life care preferences. Those preferences have an impact on the people in their lives, whether it be partners in business, whether it be family members, but they are impacted by those decisions, particularly the ones that will be actually involved in that end-of-life process. So going back to Dr. Grimm's point, if I don't tell Katie that I've appointed her my healthcare proxy, she's not likely to be happy about that because it's going to be a surprise. She may not want to take the burden, and she will be impacted by it because, frankly, there are people who don't want to make that end-of-life decision. Like the people who want me to be their arbitrator, they don't want to make their own decisions. They want someone else to do it. And if you're having those conversations, you should be very careful about who you're picking and why you're picking them and facilitating that conversation in a meaningful way. So these conversations can in fact result in conflict, and our facilitative participation is to assist them a way of working through it and what is the most useful way to do it. So if you're going to commence this conversation with your patients, you are sort of facilitating that discussion. Now, it may be one-on-one with just the patient, but the question then becomes, what if there are other issues and other people that have to be brought into it, and how do you do that? And having the resources that if you don't have the time or the inclination to do it, whether there are folks in your office that can be having those conversations, that have the right approach and the right training, because facilitating a conversation may be very intuitive to some people, but not particularly intuitive to others. And folks who are geared towards decision-making tend not to be the best facilitators for conversations. They tend to tell people what to do, and that may be helpful. That's not a bad thing, but it's not the same thing as facilitating a conversation. So being told what to do and being led through a discussion about what is it that you really want, and eliciting the information from the person themselves is very different from telling a person. You may be right, and you may have a good guess about, no, I don't think you should do that, but it is a guess, and it's you saying it to the person. So from a legal point of view, you really want to help people get to the right point and then make the right picks. And one of the ways to start the conversation is that you focus on what should be happening and whether you have that conversation. And I think I've heard folks use the phrase often and early, or early and often. How many people in the room, and I can't really see well enough to gauge the age of here, who remembers Karen Ann Quinlan? Oh, okay, great. That was, for the legal community in particular, a time to focus on issues that they tend not to focus on most of the time, and of course became a very famous legal case in terms of what are we dealing with here and what are we focusing on, and then allowing to have conversations about those kinds of decisions. And that started the whole trend about what are the documents that should legally be put into place that would allow this to happen or to not happen, depending on what side you're on, in terms of a discussion. So what are the kinds of things that you need to look at? So two concepts that come into play in having these conversations and facilitating them is the concepts of competence and capacity. So capacity and competence are two separate issues. Capacity is a practical thing. I would describe it as a practical thing in approaching a person that you're discussing this with. Do they have the capacity to understand the nature and consequences of what's being discussed, the proposals, the discussions? Can they make informed decisions? Can they consider the alternatives, evaluate them, understand them, and make those choices about them? And capacity is something that can come and go. I can have capacity depending on my condition. I can have capacity at any moment in time, but it can come and go. And you, as medical practitioners, some of you would know that better than I. But capacity is that kind of practical approach. At this moment that you are looking at signing this particular document, you have the capacity to do it. Competence is essentially a legal concept as to whether or not you are legally competent in the legal interpretation of signing binding contracts documents, instruments, and advanced directives. Everyone is assumed to be competent until they are declared legally incompetent. And again, that can lead to some discussion about mom signed this piece of paper, but I don't think that mom was competent to sign it, and I don't want to honor it, or I don't want you to honor it, and therefore I have to go to court and declare mom incompetent and have this thing set aside so that I can make decisions for her under some other surrogate decision-making process. That, again, creates the conflict that perhaps may engender a conversation about the difference between competence and capacity and the wishes of the person, and whether or not, again, pointing out the obvious, if you had that conversation earlier in life and executed the documents earlier where there was no question of either competence or capacity, then you wouldn't have the issue arising, hence the early and often component. So those are the two concepts, capacity and competence, that are good to keep in mind in terms of having these conversations. So what are these advanced directives, as I thought it was lawyer speak, but I guess you guys use advanced directives as well. I think for most humans, it's substituted decision making. Is who's going to decide for me when I can't? And I think it's the focus here is decisions being made about you by someone else. That's what advanced directives essentially are. It's when you're not there to tell people what you want, it's somebody else doing it for you. And then going back to the mediation arbitration difference, it's the voluntary versus involuntary advanced directive. Because these things are going to happen if people are incompetent, and if it happens involuntarily, then certain things will kick into place. If you do not have advanced directives, if patients don't have advanced directives, that doesn't mean that things aren't going to happen to them when they're no longer able to make their decisions. It just means it's not going to happen the way that they would have wanted it to happen. And the decisions are going to be made by people other than the people they would have wanted to make it happen and make those decisions for them. So the decision making is going to happen, and not having advanced directives is a choice. It may not be the optimal one if you want things to happen the way you should. Some folks cannot make those decisions. They do not want to think about those things, and therefore they don't want to make any plans about who am I going to appoint and what do I want and what do I don't want, because I don't want to think about being sick and dying. And that is something that we have to face every day with folks that we deal with. My father was always very clear about, I don't want to be, I just want to die. What does that mean, Daddy? I don't want you to do anything. And I'm going to give you a power of attorney, and I'm going to give you a healthcare proxy, and you're going to take care of everything. So he wasn't going to make any decisions. I was going to make all the decisions for him. But then he didn't want to talk about his funeral. So he was very clear about, you're going to be responsible, and that's as far as he wanted to go. And on the funeral, I don't want to talk about that. I'm not even going to, that's your problem, because we'll deal with that. And for my 61st birthday, he gave me very graciously the gift of his own funeral arrangements. That's not what he did for himself and my mother. He gave it to me as my birthday gift. So that kind of tells me what he wanted and how he wanted to go about doing it. But he was very clear what he wanted, and he wanted me to be responsible. So you're going to run into folks like that who are not going to want to make their own decisions. And then the conversation to have with them is, okay, well, who should be making those decisions? I'm an only child. It was really simple for me to have the blame and the responsibility for everything. But that's not always the case. And children aren't necessarily always the right choices because of their own involvement. And if there is more than one child, then who should it be? And should you be having a conversation? And I always encourage people, please, make your decisions, have your conversations, and then tell everybody and anybody, because everybody needs to know not only what your wishes are, but what your expectations are, and that you are my proxy and you are not my proxy. And here is why I made the choice, because you want to preserve the family dynamic. If mom says, well, Katie is really going to do what I want, so I have to have Katie do it, because Bob would never do what I want, because Bob is interested in keeping me around as long as possible. And that's a conversation that perhaps should happen, at least so that Bob knows that he's not going to be the healthcare proxy, that Bob knows what Mom really wants, and that Katie is willing to take the responsibility, including Bob's wrath, because she's going to do something she knows that Bob doesn't want done, and Mom does, and it's about Mom. And that's the kind of discussion that needs to be had in terms of making a decision. So it's not only just having a discussion of what do you want, the discussion then becomes, how does that come to happen for you in a way that's going to be meaningful to you? So what are the legal documents that can come into play? Obviously, the most obvious one that we talk about most is the healthcare proxy. But I'll just give you the list, okay? So no list, but here's a list. It's a healthcare proxy, it's a DNR, it's a do not resuscitate order, it's a living will, it's a power of attorney, and a MOLST. Those are the 5 most readily available. There are others, I'm not suggesting that that's an exhaustive list, but those are the most important things. Healthcare proxy perhaps being the most important because it's the one that allows someone else to make that decision for you when you're no longer able to make it in a meaningful way. And choosing a first and a second healthcare proxy is usually important because people often choose their spouses, which again may or may not be a good choice, but often you can get affected together. Spouses fly together, they travel together, things happen together. You may want to have a backup person because you may both be in a difficult situation. And there is a form, and I have a handout that has a couple of links in it. Very easy to search, pick your favorite search engine. Mine happens to be Dogpile, which is very different from Google. You type in New York State Healthcare Proxy, New York State Power of Attorney, you're going to get a whole lot of choices and a lot of information. But those provide forms that can actually be used. It's a question as to whether or not you want to be handing out forms for people to use. I think that for healthcare proxy, doctors tend to do that. I know my doctor does it. And a few times I've been in the hospital with other folks is the hospitals also give you forms and encourage you to sign them, which I think is important. And so that you can start with the form and you can have the conversations with folks about what that form looks like. It's very simple, 2-page, self-explanatory. I appoint so-and-so to do such and such. If you want to get more involved, then there is a living will, which is much more specific about your end of life, which is healthcare proxy can kick into for healthy people for temporary periods of time. So this is the person who substitutes for me if I can't make decisions. Not necessarily that I'm dying, but I'm in a coma, I'm in a car accident. So this is the person who's going to tell you what to do, and generally it's simple. Do whatever you can to get them right and make them healthy again. Living will is a more complex document. It's much more customized and individualized in terms of what do I want done and not done at the end of life generally. After you have the conversation, after you're going to healthcare proxy, you will then be executing both the living will and your decision making. What are the general things? But there are specific things that are very helpful to legally have the hospitals and care providers be able to do. DNR orders and things that are very specific. You get to them through the discussion we've talked about earlier, but you have them in terms of do not feed me, do not keep me alive by artificial means. All of those things are very specific, and that's the conversation that really leads to that end result. And a living will is how you put it out there and having the conversation about creating the living will and making all the people who are going to be living the consequences of your living will and have to be willing, able to execute it for you. DNR is pretty simple and straightforward. Power of attorney is a much more advanced concept, and it is much beyond healthcare decision making. But when they're looking at those types of issues, and depending on the nature of the patient, it may be something that could come into play. It gets more complicated. There are forms generally available and people can execute them. It can be better to do it with the assistance of an attorney, not required, but can be helpful in terms of understanding the consequences because it does give powers way beyond just healthcare decision making. And then in terms of doing really long-term planning as to what should happen is looking at the possibility of MOLST And they are very simple forms as well now. And there is a lot of support, a lot of information available out there. So those are the documents that would end up being the legal way of effectuating the end result of what hopefully will be these meaningful conversations. So my recommendation for a checklist for these conversations, and practically for most conversations, is the 5 W's. It's the who, what, where, why, and when. So who should you be having this conversation with? Pretty well everybody. But the who also goes to who is going to be the person who's going to be my decision maker, who's going to be my surrogate decision maker, who's going to be my healthcare proxy, who's going to be the person who will do what I have. And who do I have to have this discussion with, and who do I need to facilitate that discussion if it's not going to be a pleasant one. The what part of it is the what are we talking about? What am I going to be telling these people? Am I going to be sharing with them the information about what I want at my end of life, and what I want until that point in time, and how I want to go out, and what are the elements that are important to me, sort of that list that was up there before in terms of what are my fears, what are my goals, and how do I want to deal with those things, and how do I create the document that's going to show that. When do I do it? Early and often and early, all the time. Update it, look at it. Hard to have a conversation with 21-year-olds. You're more likely to have it about their parents, and once they talk about their parents, they may start thinking about themselves. Revisit it, it may change. Technology changes. There were ways to keep people alive now. Keeping them alive means that their heart is beating and they're not buried in the ground. And that may change people's opinions about what they want to and don't want to do. And if they feel very strongly about not being a vegetable, what does that mean? Let me define it in my living room. This is what it should look like. Make sure that they then get the information and that they actually execute the documents that set it forth and have those conversations. Because that's really having a conversation, oh, I'll think about that, that's a great idea, I need to do that, it's on my do list, is not going to help when they actually need the help. Where should you be doing it? You should be doing it someplace private, someplace sensitive, someplace comfortable and safe. Whatever that looks like, whether that's during an office visit, whether you have folks in your office that can just be there for facilitating those kinds of conversations, whether you send them to the Conversation Project on your website or other resources locally available, that's all terrific. Or you get a conversation started and they say, well, I can't do that, I can't tell my daughter. Well, who can you talk to that perhaps can sit down and help you facilitate a conversation? And that's get involved with the facilitator in that. And how do you do it? You do it with compassion, understanding, and determination. Because what you're trying to do is focus people on something very uncomfortable and very necessary, because it is inevitable that end of life is going to come. It's simply a question of focusing on how you plan for it and how you, as a neutral, whether it's a healthcare provider or mediator or anything else, can help them focus on something that they may not want to focus on, but need to focus on in a compassionate, helpful way in order to come up with a result and a document at the end that can help them get what they want at a time when they're no longer there to express their wishes. If there are any questions, I'm available as a resource, and